Hello everyone, I welcome you to a lecture on dermatology. Here we will be discussing the following conditions. I will provide a timestamp so that it is easier for you to navigate. Let's talk about the HPV associated penile lesions. How will the human papilloma virus, when it causes a penile lesion, how will it be? It will be a what kind of growth? So this is how the question will be. Skin colored, or it can be even dark colored, painless, and it will be 4 millimeter growth on the penile shaft. It will be a typical growth, and there will be no ulceration in the human papilloma virus. Will it be painful or not? It will not be painful. It will be painless. Now, just to refresh our memory, what is the other condition which is also painless? Yes, it is a syphilis. What is the other condition which is painful? Yes, it is herpes simplex virus, Haemophilus ducrei, resulting in chancroid. They both are very painful, but this is painless. Now, what is the organism which causes the warts? In human papilloma virus, there are four important strains. HPV 6 and 11 will cause condylomata acuminata, or they are also known as genital warts. They are the one which is also responsible for laryngeal papillomatosis in newborn. Why? This is because of direct vertical transmission from the genitals to the vocal cords during birth that can result in laryngeal papillomatosis. What about human papilloma virus 16 and 18? They are the ones which are responsible for malignancy. So they are associated with the cervical malignancy, vaginal malignancy, or the penile squamous cell carcinoma. What do you know about anorectal malignancy workup? Here, the vignette will be 55-year-old male with a fungating rectal mass. What is the next step? The next step can be the next step can be either of the two. If there is a rectal mass fungating, then whatever it is, our suspicion from the doctor side has to be that it could be a cancer. So either we need to do a biopsy, but if biopsy is not listed, then what will we do? We are not supposed to remove the lesion as such. We need to see the extent of it. Therefore, a colonoscopy or the anoscopy should be done to see the extent of the growth, and then it has to be treated. See, it can be another vignette where a 3-month-old history of a pencil-like stools with a 3 centimeter fungating mass at the anal verge. So, because of the fungating mass, what is the next best step? Colonoscopy is the next best step if biopsy is not given. This picture can be given and ask you to diagnose it. This is Peutz-Jeughers syndrome. Here there is perioral melanosis. If you see it, it results in a hyperpigmentation around the mouth or the lips. When you see a hyperpigmentation around the mouth of the lips, it is associated with a hamartomatous colonic polyp. What do you mean by hamartoma? Is it a benign or a malignant, or what it is? Hamartoma means the tissue which has been produced as a growth is the tissue which is inherent to that structure, but it has a disorganized growth, so resulting in a hamartoma or that nodular pattern. Even though it is benign right now, this Peutz-Jeughers syndrome has an increased cancer risk. Where else do we see perioral melanosis? Perioral melanosis is also seen in Carney's complex. Carney complex is a high yield in MLE exams. It is associated with the three conditions like cardiac myxoma, perioral melanosis, as well as endocrine hypersecretion. What is this? This condition is Burkitts lymphoma, and here you are seeing the Burkitt lymphoma presenting with a jaw lesion. So the picture can be given, and the vignette will be 6-year-old male with a jaw lesion. What is the molecular function of the involved gene? The gene involved is a transcription factor. Now the translocation 814 is responsible for a Burkitt's lymphoma. The gene is a c-Myc gene which codes for the transcription factor. Histologically, we will be having a starry sky appearance. What is the other condition which is almost similar to Burkitt's lymphoma? That is follicular lymphoma, where the translocation will be 1418, and it will code for BCL2 gene, which is an anti-apoptotic. There will be a waxing and a waning neck mass over 1 to 2 years. This is how a follicular lymphoma will present. Tongue lesions. There are two important tongue lesions. One is leukoplakia, the other one is a hairy leukoplakia. The leukoplakia is the one which will have a curd-like deposit over the tongue, and if you scrape it, it doesn't scrape off. That's how the leukoplakia will be. Whether, if you ask me whether it is precancerous or not, it is definitely precancerous, and it progresses to squamous cell carcinoma. What is the predisposing? It is mostly seen in people who smoke and who are chewing tobacco. The similar condition is oral hairy leukoplakia. The oral hairy leukoplakia will be seen, it is caused by Epstein-Barr virus, and it is also a similar white lesion that doesn't scrape off. But what is the difference? This is caused by the virus, and this is not precancerous. This is not precancerous, unlike the leukoplakia. So even though the name looks sinister, like oral hairy leukoplakia, but it is not precancerous and it is caused by Epstein-Barr virus. But the general leukoplakia is precancerous and it is caused by smoking as well as chewing tobacco. In HIV associated also, because of the immunocompromised state, we have oral hairy leukoplakia because they are more prone for the infections, right, because of the immunocompromised. So Epstein-Barr virus induced hyperkeratosis causing white lesions on the lateral border of the tongue is also seen in HIV. Another one is the candidiasis. Oropharyngeal candidiasis is also commonly seen in HIV. What is this condition? If you see here, this is the cutaneous T-cell lymphoma. What happens here? This is because of a malignant T cells with cerebriform nuclei. What is the reason for this? The reason for this is HTLV, human T-cell lymphotropic virus. The human T-cell lymphotropic virus is an RNA virus. I will show you the structure in the next slide. It's an RNA virus and it will be similar to HIV virus. So it is an RNA and it is enveloped similar to the HIV virus. Whatever you are seeing here, this condition is called, it is of course cutaneous T-cell lymphoma, and it is known as Mycosis fungoides. How will the biopsy be? The biopsy will have malignant T cells. What do you mean by malignant T cells? Malignant T cells they will be proliferating at a higher rate. The normal T cells gets converted to malignant T cells and they will be proliferating at a higher rate. The apoptosis will not happen at the normal rate. And they will not be looking like a normal T cell. That is, they will be having a cerebriform nuclei because of increased convolution of the nuclear membrane and increased aggregation of the chromatin. What about this? This again is a picture of the Mycosis fungoides. I just wanted to reinforce it. That's why I have this. So here there is one more appearance, that is it has Portreous microabscess. What do you mean by that? These atypical T cells, that is which have the cerebriform nuclei, the aggregation of atypical T cells in the epidermis is known as Portreous microabscess. What do you know about this? This is the Sezary syndrome. This is when the Mycosis fungoides, which is limited to a particular area, when there is an extensive extension of Mycosis fungoides throughout the back, then it is known as a Sezary syndrome. Again, one of the reason for Sezary and mycosis is HTLV. See, this is the enveloped virus, and just similar to HIV, this also has the structure, and it is a retrovirus. So this picture can be given, and the vignette can have details like 54-year-old male with IV drug history use, presence of diffuse red body rash, and the blood smear shows leukemic T cells with cerebriform nuclei. They do give us almost the entire details to diagnose the condition. How will the pancreatic cancer be presenting? So the vignette will be 82-year-old female with a remote gallbladder removal at age 58. Now she is presenting with jaundice and she is very febrile. So when they tell you that the gallbladder has been removed almost 1 or 2 decades ago, then it means that they clearly tell that it is not because of cholelithiasis. The stone or the obstruction or the jaundice is not because of cholelithiasis. That is the first one. And the stone is not lodged in the cystic duct too, because that is also removed. Fine. Now we are left with only the bile duct structures as well as the pancreas. Here they tell you that they are presenting with the jaundice. So either it can be the stone in the bile duct, or it can be a cancer of the pancreas which is impinging on the bile duct. So the clinical reasoning is that what the cholecystectomy is done, so therefore that jaundice has been ruled out. Now the next best step, what should we do? We are supposed to look for cancer, that is pancreatic cancer or bile duct cancer. Therefore CT abdomen is done for pancreatic cancer evaluation. If CT abdomen is negative, what should we do? If CT abdomen is negative, then we are supposed to look for cholangiocarcinoma, that is bile duct cancer, which can be missed in CT abdomen. Therefore we are supposed to do ERCP to evaluate the cholangiocarcinoma. One more point I want you to know is that the head of the cancer will impinge on the common bile duct, causing jaundice with elevated alkaline phosphatase as well as direct bilirubin. But what about the liver enzymes? In pancreatic cancer, the liver enzymes will all be normal except alkaline phosphatase. What do you know about glucagonoma and MEN1 syndrome? The presentation will be 40-year-old male with a shooting groin pain, elevated serum glucose and red abdominal rash. So shooting groin pain, it indicates that it is hyperparathyroidism. Elevated serum glucose, it indicates that it is glucagonoma, and the red abdominal rash also, that condition which is seen in glucagonoma, that is necrolytic migrating erythema, is also present. So these three are correct diagnostic of MEN1, which will be presenting with the pituitary tumor, pancreatic, and so the pancreatic is glucagonoma, pituitary tumor, pancreatic, and the parathyroid. So parathyroid is the one which is presenting with increased calcium and therefore shooting groin pain. Let's see this vignette before we go to the syndrome. 40-year-old male who is presenting with facial flushing, diarrhea and low serum potassium. So what is the condition? So VIPoma, when there is excess secretion of VIP, that is vasoactive intestinal peptide, then it presents with a syndrome known as VADA. What is VADA? W and D stands for watery diarrhea, H stands for hypokalemia, and A stands for achlorhydria. So this is what they are presenting, that is diarrhea and low serum potassium, and it presents with the facial flushing too. So watery diarrhea, hypokalemia and achlorhydria are characteristics of VIPoma. In addition to it, in VIP secreting tumors there is facial flushing too. So this picture can be given and then they can ask you, a 27-year-old female at a 20 weeks gestation with scattered skin lesions on the trunk and the arms plus axillary and groin freckling. So this is the typical cafe au lait spots. The question will be, what is the inheritance pattern? The inheritance pattern of neurofibromatosis is autosomal dominant. This is the cafe au lait spots. It is one of the phacomatoses. There are many disorders which are categorized under phacomatoses, which are the neurocutaneous disorders, and one important one is the NF1. In addition to cafe au lait spots, we will also be having neurofibromas, axillary and groin freckling. Optic gliomas can develop and affect the vision. And increased risk of euchromatoma is also seen. So here we need to know about the inheritance pattern about neurofibromatosis 1. In addition to neurofibromatosis, tuberous sclerosis is also autosomal dominant. The picture can be given and they can ask you to find out the inheritance pattern or the disease. This picture is indicating adenoma sebaceum. Adenoma sebaceum is a component seen in tuberous sclerosis complex. What are the other features? One is adenoma sebaceum, as you see here, which is angiofibromas, that is a characteristic facial lesion. The other one are that there will be intraventricranial and periventricular nodules resulting in, that's how the name, that is the tubers, resulting in tuberous sclerosis. There will be adenoma sebaceum in the face. There will be subungual, that is under the nails, there can be fibromas. There can be ash leaf spots as well as shagreen patches. Cardiac, they can have cardiac rhabdomyomas, lymphangioliomyomatosis, as well as renal angiomyolipomas. These are the systemic manifestations in tuberous sclerosis. The important point here I would like to tell you is tuberous sclerosis as well as neurofibromatosis are autosomal dominant. What about the Sturge-Weber? I will show you a picture of the Sturge-Weber in a short while. Here they will be having a port vein stain birthmark. So that is how we had usually read in the book. It is a nevus flammeus. There can, but in MLE exams they will be giving you like a violaceous papules in a temporal distribution is present. It is exactly the same way of elaborating port vein stain birthmark. In addition to it, there can be leptomeningeal angiomas which cause an increased risk of seizures as well as glaucoma risk. So this is the typical port vein stain that you see here. What we need to know is this is not autosomal dominant, this is not autosomal recessive, it is not inherited at all. It results from a somatic mosaicism during embryonic development. So with this we have come to the end of our dermatology presentation. I am a medical doctor. My name is Dr. Veena Velmurugan. I am an anesthesiologist. I love to teach. if you are a medical graduate or if you are an USMLE aspirant, and if you like my videos and if you want to get mentored by me, I am more than welcome. You can write to me in the comments, and looking forward to see you succeed.